Well, thanks for being here, Nicole. There's been a lot of discussion over the years about amphotericin B. Should you or shouldn't you use it with your corneal transplant tissue? Is it worth having it in your storage media? What are your thoughts?
I think there's a few times in your career where you're really excited about the research that you're performing and the ability to do this with CorneaGen and partner to answer a question that is so important for our patient outcomes was really exhilarating to me as a clinician and as a clinician scientist. What I would say is that the most dreaded complication of any corneal transplantation or any intraocular procedure in general is a fungal infection because it's so difficult to treat and can be devastating to your outcomes. So, to be able to look at thousands of patients and really answer a clinical question, number one, will it decrease infection? That's the first question. And number two, is it safe? Are we doing something to our tissue to make it unsafe or cause undue outcomes to our patients is extremely important to be that critical when you're introducing something relatively new to the United States.
Well, absolutely. And so this is a pretty great retrospective review paper that you presented on. Pretty compelling data. It showed that use of amphotericin B supplemented storage media had a tenfold reduction in fungal infection with no statistical significant increase in primary graft failure and early regraft in the EK group. Is that correct?
What was so interesting, we look at over 50,000 transplants, and what we found was that for the DSEC and DMET cohort, that there was no statistical difference in primary graft failure in that cohort, which was encouraging. Although in general, there is an increase in primary graft failure in EK because there's more manipulation of the tissue than with PK. What's interesting though is when we looked at all comers, there was a statistical significant difference between amphotericin B supplemented and non-amphotericin B supplemented cohorts. And so what I think we need to do is take out the PK patients and analyze that and look at maybe why, even in the lab, why one group would be more susceptible or gather more patients to figure that out. So it's not to say that that cohort of patient in our EK group does not have more primary graft failure, but the
Mhm.
amphotericin B addition did not cause a statistical difference between the groups.
Right. And that's been a little bit of the discussion that's been out there as well is, um, you know, a fungal infection versus a little bit higher chance possibly of primary graft failure. I think every surgeon maybe has their own threshold of that decision if they want to add it or not.
Absolutely. So I think if you're someone who's never had a fungal infection in your career, you'll say, well, why would I cause so many primary graft failures um, as opposed to just not supplementing? But in general, if you've ever had one in your career, it's something you never want to see again. And so I can redo an EK or a PKP. I can't redo a fungal infection.
Right.
So I think that's, kind of the risk benefit ratio that you have to think about.
Right. Well, again, it was a large data set over 4 years, 53,000 graphs. About half of them were supplemented with Ampho B. So a great retrospective comparison for the 10x decrease in the fungal infection. What do you think the next steps would be for this line of
Well,
research?
I think the first issue is that we're not necessarily getting the reporting that we need from surgeons. So I think we need to have a system where you can have immediate and real time at 1 month or even 1 month, 3 months, where you can really find out how the patient's doing. We did look at all comers. We didn't stratify by how many patients had repeat PKPs or repeat EKs. Obviously, if there was a pattern, the medical director that looked at all the adverse events would say this needs to be excluded from our analysis. But we did look at all comers, which is a good thing. But I think a more systematic way that we are reporting our outcomes would be really important. I do think people report fungal infections
Right.
accurately, but in terms of primary graft failure, I'm not sure that we're getting the real-time data. So that would be the first thing. The next thing would be to do a prospective study and maybe to look at, different concentrations. Uh, we achieved, statistical significance in looking at the fact that there's no increase in primary graft failure with EK and um, DMEC and DSEC, but maybe we need to really do a prospective on this PK data and see if there is something different that's happening with PK tissue. And why was that? Why did that change the all-comer data as statistically significant? So I think a prospective study, I think looking at different concentrations of amphotericin, whether they are the pellet form, whether it's the liquid form,
Mm.
why did the EBAA have different data than we had, or preliminary data? I think all of those things need to be sorted out.
Right. No, absolutely. And definitely a great point being made. Until we have something on the lines of a registry, there's always going to be that underreporting of the primary graft failures and early regrafts. So thank you for your time today, as always, and enjoyed sharing that information, particularly on the amphotericin B. For more information to include amphotericin B on your tissue, please contact your surgeon advocate, or you can email us at tissue@corneagen.com. You can also check out our extensive library of great content, surgical pearl videos, and recorded webinars at corneagen.com. All the best. Thank you.
Thank you.